Assalamu alaikum. Welcome everyone on board. We have started uh, our discussion on the basis of MCQs and just to explore how to learn with different MCQs and what are the different points which you can explore even from one MCQ. Okay. So I think this scenario is with reference to trauma. So we have a 28 years old pedestrian struck by a bus, presents to the emergency department in hospital. He has had a primary survey which reveals an obvious head injury. So one point came is head injury. Okay. So in head injury, what are the initial consideration? This thing should be in your mind. He also appears to have a fracture to his right arm. So there is right arm fracture. Then chest is clear and a fast scan of abdomen is negative. So abdomen is clear, uh, chest is clear. Okay. And there is confusion. The medicine registrar, emergency medicine registrar has asked you to sedate him for a CT scan of his head. So just a review that what will be the indications of CT scan in a head injury or a trauma patient. On examination, he grimaces and groans to a deep, painful stimulus, but does not open his eyes. He flexes his left arm and leg. So you have to identify what is the GCS of the patient or how to identify the GCS of the patient. Sorry. Yes. So now you just have to concentrate on this in this patient that what like the consideration they have not given any uh, hemodynamics in this patient. So you should be knowing about it usually. And let's see. But I think they have just give you an idea that there is no life-threatening injuries. Okay. So let's see. Titrate small doses of propofol to effect with continuous monitoring, including waveform capnography. Will this be a good idea? Let's see. I don't think so. Refuse to give sedative drugs on the count of his depressed conscious state, but accompany him to the scanner. This is not possible again. Okay. They are in this option, they are saying about this monitored anesthesia care. Uh, okay. Perform a rapid sequence induction with propofol and succinylcholine and transfer with a propofol infusion. Okay, let's see. This is one option. Then perform modified rapid sequence induction with the 1.5 milligram of succinylcholine after 2 microgram per kg fentanyl and propofol and manual inline stabilization of the cervical spine. Okay, this is also seems to be a good option. Fit a Miami J collar and blocks and then perform a modified rapid sequence induction with 1 milligram per kg rocuronium and 3 milligram per kg of ketamine. So this option is not a good option because of a high dose of ketamine. So I think this option is gone. And let's see what is the answer.
Option D seems correct.
Yes. Like if we come back, the main thing is that if you compare here and here, the difference is only with manual inline stabilization. Okay, mainly. So here also succinylcholine and even better, they are blunting the stress response. So rest of the option, like because in this the points which you can learn from it, this MCQ as well, that in such situation when you have low GCS and there are like the patient conscious level is also not good. If you will give a small sedative dose, now the patient will be difficult to control the airway. So this option is gone. This option is gone and this option is also gone. So there was tie between this option and here because manual inline stabilization is there. So that is why this is, let's see what is written in details. So another option is that whenever you have a patient with the head injury, you have to prevent the because primary injury has been done. So your aim of anesthesia management is to prevent the secondary brain injury. Okay. So what are the Wajiha, can you tell what are the factors which can lead to secondary brain injury or exaggerated secondary brain injury?
Sir, hypoxia or hypercarbia, hypotension,
Okay.
acidosis, which will lead to ischemia and second edema, that will also cause
Yes. So on the
necrosis and then secondary bleeding.
chest
The
difficulties.
main factor is
Yes, it's like you would avoid hypoxia. You just have to maintain the cerebral perfusion pressures, and you just have to think about the Monroe-Kelly doctrine that if any factor which is increasing the ICP, if anything which is disturbing the cerebral blood flow, which is increasing the pressure or decreasing the perfusion pressures, okay, and increasing the cerebral blood flow actually. So it can cause increase in chances of secondary brain injury. So O2, CO2, viscosity, and maintenance of cerebral perfusion pressure. These are all things which you need to do in this scenario. Okay. Another important thing is in this scenario is also the manual inline stabilization, because you have to consider cervical spine injury um, uh, unless it is cleared. So what is the criteria? We all know is Nexus criteria or Canadian C spine class. Okay. So the initial resuscitation and assessment should be a long familiar treatment alongside algorithm of ABCDE, but with treatment and stabilization of each problem simultaneously as assessment continues. So what I used to say that assessment, evaluation, and resuscitation will go side by side. So even one episode of hypotension has been shown to double mortality. The aim is to maintain cerebral perfusion pressure in face of high ICP, mean arterial pressure minus ICP. So international targets it differ slightly, but a widespread mean arterial pressure target is 90. So because here ICP is more, so that's why to maintain cerebral perfusion pressure of around 70 to 80, you have to maintain mean arterial pressure like that. Fluid resuscitation to normovolemia would be the logical first step with vasopressor following if required. Crystallite is better with some evidence of harm with albumin collide. Uh, I don't know the reason about it. Um, Anyone know about it? This thing? What will be the problem with albumin? I don't know. Maybe with reference to I don't know. I have doubt about this statement. Hypotonic dextrose solutions must be avoided. Yes, this is about hyperglycemia is not a good thing. It will increase the secondary brain injury. Okay. And of course, hypoglycemia is also dangerous, but you don't have to give hypotonic dextrose solutions because it will also contribute to tissue edema. Okay. Then intubation is indicated for a deterioration in GCS less than 8 or if there is a failure of patient's protective air reflexes. Any disturbances in oxygen and ventilation lead to hypoxia or hypercapnia is likewise a mandatory indication as hypoxic episodes are shown to worsen prognosis. Okay. Hypercapnia will increase cerebral blood flow and ICP. So similarly, a patient hyperventilating to hypocapnia must move to controlled ventilation because hypocapnia will also cause cerebral vasoconstriction. Okay, they will with cerebral compromise the cerebral perfusion. Other indication includes those that may compromise the airway if not dealt with, such as bilateral mandibular fracture, oral bleeding, or seizures. Targets again differ, but a PO2 of more than 10 kPa means more than 75 millimeter of mercury, and a PCO2 range of 4.5 to 5. Again, I think it seems to be a 5 means uh, 38. I think it's to be precise, it is 33 to 35 millimeter of mercury. It's multiplied by 7.5. Okay. Uh, Managing ICP outside of a neurosurgical center, intracranial hypertension is either a presumptive diagnosis or made when so severe as to bring about herniation. So when they word say herniation, you should just recall what are the places in the brain from through which the brain herniation can occur. Anyone remember it? Uh, this is just one of the thing to do. So you should be knowing what are the places in the brain from through which the brain herniation can occur. Um, you can Google it, or you will find an associated pupillary unresponsiveness where facilities exist for monitoring the level at which our treatment should begin is more than 20 to 25 millimeter of mercury. Usually, there the ideal way will be for any monitoring with the bolt or interventricular drain or something like that. But usually it will be clinical diagnosed clinically, unless you have placed something to monitor directly. Otherwise, you can have this clinical parameters of the Cushing response, hypertension, bradycardia, and abnormal breathing. Okay. And if the patient is like awake, maybe conscious level deteriorate, maybe fits occur, maybe nausea, vomiting occurs. So there are so many things which are with signs and symptoms of raised ICP if you are not monitoring directly. Okay. Hyperosmolar fluids such as mannitol and 3% saline raw water fluid from the intracellular space back into the interstitium and vasculature. Fewer complications are seen with hypertonic saline, and doses depend on the concentration available. But 3 ml of 3% or 2 ml per kg of 5% are reasonable, titrated to a serum sodium of less than 155. Hyperventilation has shown to compromise cerebral perfusion. Okay. So you don't need to do hyperventilation. You need to just maintain um, around 33 to 30, 35 of um uh, this PaCO2. And remember one thing, when you are monitoring end-tidal CO2, end-tidal CO2 reading is less than PaCO2. The difference is around 5. So practically also, what how you manage is that when you are drawing the sample for ABG, you will look at the end-tidal CO2 level, and when it comes the reading, you just have to compare. And after one or two readings, you will be sure that how much is the difference. So then you can monitor through that. Usually, it is difference is of around 5 millimeter mercury. Okay, hypothermia reduces ICP and cerebral metabolic rate. So this is the concept of even the better neurological outcome after uh, cardiac arrest even. Okay, used in neurosurgical center for this reason. The target temperature and duration to achieve benefits are not known, and as no benefit yet been reliably shown, most would ensure mild hypothermia around 35 and ensure prevention of fevers which are known to be harmful. Liquid sedation will reduce the cerebral metabolic rate, muscle relaxation, preventing coughing, and associated rise in ICP. There is extrapolated use using barbiturate. So barbiturate, is also used as a burst suppression in some cases of raised ICP, but is associated with significant hypotension. So you just have to understand. In the above patient, the GCS is E1, V2, M3. Just to recall how it was, uh, premises and groans to deep, painful stimulus, but does not open eye. So eye is 1 and flexes. So it is, I think, 3 and verbal is 2. So it is incomprehensible sounds. So E1, V2, M3 is a 6 GCS. Okay. In the context of a head injury, this is an indication for intubation. The patient meets the criteria for immediate CT scanning, and the need for imaging in this patient also mandates securing the airway prior to scan. There is a dangerous mechanism of injury, and the C spine is compromised until unless prove otherwise. So, C spine control is needed for intubation and scanning. Clearing this clinically is no longer possible due to conscious level. even if the GCS were 15 with a distracting fractured arm, one cannot clear the neck confidently without imaging. Okay, so if you remember, one of the reason of one of the factor for not clearing is distracting pain, intoxication, okay, tenderness. So there are those, this is what is nexus criteria. So the final discriminator here is a choice of drugs, okay. Priority is rapid control of the airway with muscle relaxation, whilst preventing either hypertension and raised cerebral blood flow, therefore increase ICP, or hypotension with a fall in cerebral perfusion. You have to prevent both of them. So most will achieve the former by using of an opioid, later with conscious use of induction agent. Ketamine has recently been shown to have no effect on increasing ICP, but a slightly lower dose. Okay, but the dosing of 3 milligram per kg is high, and a dosing of 1.5 to 2 milligram is likely sufficient. Similarly, for muscle relaxation, classical teaching has urged against dexamethasone because of a transient rise in ICP. However, the rise is small and for most part offset by the fall in perfusion pressure caused by the co-administration of induction agents. Therefore, the most appropriate course of action in this patient would be to perform a rapid sequence induction with fentanyl, dexamethasone, and propofol and manual. Practically, there are so many things which you can doubt in this scenario even, because now if there is availability of rocuronium, it's always a better choice than dexamethasone, because transiently it will cause uh, and, transiently it will increase, but you can like you can avoid. If you have rocuronium, you can easily avoid. This is practice FRCA MCQs. Okay, in the recordings I have kept the link for it. Okay. Anyways, so in this MCQ, what are the reading? Even you can just revise your trauma concepts. Okay. So what is the primary survey, secondary survey, how to manage the immediate life distracting injuries, because they have categorically told us about chest, about abdomen. Okay, and they have put a long bone fracture. So whenever there is a long bone fracture, there may be chances of bleeding, and there are chances of embolism. Okay, pain is a factor, and you have to do the C-spine care. Okay, so there in one question you can revise so many things. Another thing is that what are the what are the indications for CT scan? Okay, and another, they have here transfer, the word transfer, so you can think about the patient transfer as well. So in this one MCQ you can use like a brain exercise for so many points. Okay. Okay. A 19-year-old man presents with the district general hospital emergency 8 hours after suffering a penetrating injury to his anterior chest. He has a Glasgow score of 15, heart rate of 105, blood pressure 95 by 50, saturation 99, and hemoglobin of 105. Transthoracic echo shows hemopericardium, for which he requires transfer to a nearby cardiothoracic center for exploration. What pre-transfer intervention is most appropriate? Uh, Actually, in this scenario, they are uh, telling the patient is hemodynamically stable, but patient has like a cardiac injury in which there is blood is there in the pericardium. Okay, so needle pericardiocentesis will not be required in this scenario because they are transferring the patient for and the patient is not collapsing at this time. Intubation and ventilation. Again, intubation and ventilation is not required. Patient is stable. Insertion of a pulmonary artery catheter for cardiac output monitoring. This is also not required. Insertion of invasive arterial and central venous line. This is one point. Transfusion of 2 units of PRBC is not required. So, though needle pericardiocentesis will be required if the patient is having signs of you can say cardiac tamponade, okay, and what we say Beck's triad, in which uh, yes. So you should be just thinking of pulmonary artery catheter for cardiac output monitoring preoperatively is not a mandatory thing. Okay. One point I just want to request you. Uh, these are all you people say this book. I say it practice. Okay, because unfortunately this is just in your mind that you want a book from which they are making the question, and this make you negative in your approach. I'm not saying that you should not look for something which can come directly in the exam, but believe me, even if someone has taken the text from this question, he can easily change some statement. And so, for example, if you have crammed the answers, you can be distracted. So even if you see, oh, this question I have read somewhere in Baghdadi or whatever you say, Lahori or Karachi or whatever. So don't try to make your mind fixed mind. That's why I never encourage you guys to look at some very specific source, because this can distract you. Because even in this question, I have doubt about the PCO2 level they have put. I have doubt about use of albumin. I'm not sure about it, but I will not make it 100%. I would like you guys to reconfirm. Similarly, that's a problem when you are just cramming the answer of previous pool and not understanding the knowledge. Okay, so that's why even if you are so many questions are repeated, even then people fail, because I know that even some people are uh, copy copying the question, they change some statement, and then you are confused and you don't know whether that's the correct answer. So that's why I humbly request you, don't concentrate on specific book. And even if you see, oh, this is from Baghdadi or Flana, don't become prejudgmental. Okay, this is my request. So transfer to specialist surgical services, although not in extremis in condition, may become compromised during transfer, and adequate resuscitation and pre-transfer plannings are essential. Motion artifact may make non-invasive blood pressure readings unreliable, and continuous arterial blood pressure monitoring in these situations is more appropriate. CVP provides a reliable form of intravenous access and allow for the use of inotropic or vasopressor support should the need arise during transfer. Use of pulmonary artery catheter and cardiac output measurements by thermodilution is not practical during transfer and will not contribute to his patient's management. This is the point. Intubation and ventilation monitored with continuous capnography should occur pre-transfer in patients in whom airway and ventilation may be compromised. Okay, neither of which are a concern in this case. Pericardial clots may prevent adequate pericardial drainage, and blood may further accumulate. Pericardiocentesis is in a non-cardiac center without immediate surgical support should be carefully considered and may unnecessarily delay transfer. It is indicated in patients with significant hemodynamic compromise. Okay. Although a hemodynamically unstable patient with a penetrating chest wound likely warrant a thoracotomy, aggressive fluid resuscitation in patient with penetrating injuries should be cautious, and goals should be to maintain an adequate filling pressure, heart rate, and contractility. Okay, blood should be cross-matched and available to administer in the ambulance if required, and tranexamic acid would be an appropriate and adjunct in this circumstances. Um, that, like you see, they have made it again in this question also. There is the concern with reference to inter-hospital transfer. So you should be knowing what are the concerns during the inter-hospital transfer or intra-hospital transfer from one unit to the other unit. So you should be knowing what are the requirements for that thing. And in this scenario specifically, they just want you to understand that in which scenario you like, because the main point in this question was what you need to do before. So pericardiocentesis you will not do, and this pulmonary artery catheter is also not required. So that's why they have selected this answer. Okay. Okay. A 62-year-old man who sustained an isolated non-penetrating chest injury resulting in lung contusions and rib fractures is on the intensive care unit, intubated and ventilated. So you should be knowing that what are the sequelae of lung contusions, rib fractures, what are the concerns, what can be the complication, how to manage the pain in such patients. Okay. He has deteriorated over the past 72 hours and now has PF ratio of 50. So it's severe ARDS. You should be just revising what is the criteria for PF ratio. With a high FiO2 and a positive PEEP of 5, the investigation suggests that he has developed ARDS. The most important first intervention, they are asking you the first intervention. So furosemide 40 milligram intravenously commence an infusion. I don't think so. Administer a neuromuscular blocking agent. Okay, this may be because they want lung protective strategy. Perform a recruitment maneuver and incrementally increasing the PEEP to above 14 centimeter. I think this is too high. Adjust the ventilator settings to ensure tidal volumes of 6 ml per kg and a peak pressure of less than 30. Prone the patient. Prone position is used, but not like this immediately. So I think this is also not an answer. This is also, I think, either it is B or D, because the concept is that you need to have to avoid excessive airway pressures. So this is one point. How to do this? Let's see what option they have given, because they have given very less data. Intubated and ventilated, and now has PF ratio. So let's see what should be the answer. Recruitment maneuver increasingly, like I don't think so. This is an answer. Let's see. Oh, we could perform a recruitment maneuver and incrementally increase the PEEP to above 14. Okay. ARDS was first described tachypnea, pulmonary infiltrates, decreased pulmonary compliance, atelectic lungs with alveolar edema and hyaline membranes on pathological examination. 1994, this is Berlin definition. Acute clinical onset, bilateral infiltrates, no atrial. This was old one. Uh, okay, so respiratory failure now needs to occur within a week of a known initiating process. Heart failure no longer needs to be excluded, but must not fully explain the patient's respiratory failure. Acute lung injury no longer exists. So actually, this is the new criteria, the Berlin's criteria. Uh, there is an escalation protocol on how to manage such patients, starting with simple maneuvers and ending with desperate measures. Recruiter maneuvers to improve oxygenation. There are several methods. Most involve a transient increase in PEEP and peak ventilatory pressure, which can be performed using a manual technique on the ventilator. Uh, Ventilator strategies, which includes an appropriately high maintenance PEEP more than 14 with a tidal volume of less than 6 ml per kg and peak pressure of less than 30. Other ventilator settings such as reverse inspiratory ratio, like usually expiration is more here, they reverse it, or even equal 1:1 or even 2:1 to increase the oxygenation time. Fluid balance management is key for more long-term management. Recent evidence suggests that avoiding a positive fluid balance increases ventilator free days and may reduce mortality. Avoiding a positive fluid balance. You don't have to give too much fluid. Prone positioning has recently been shown to improve oxygenation, improve 20-day and 90-day mortality, and is not associated with increase in complication. Can anyone tell what is the advantage of prone position? Yes. Actually, when we do the prone positioning, alveoli which are not ventilated, they have they because of gravity, those lungs area are getting the blood flow, and so VQ mismatch improves. So you can say it's always intermittent proning. Okay, this is the concept. ECMO is becoming increasingly used. So you should be knowing few words about ECMO. So in ECMO, actually, it's like you can say what is difference between ECMO and bypass. In bypass, both membrane oxygenation and blood pumping of heart is bypass. Like there is a flow, so there is a pump circulation. So even heart is not pumping. However, in ECMO, the heart is pumping. The purpose, the use of the lungs are bypassed, and artificially oxygen is transferred in the blood through a extracorporeal membrane oxygenation, like out of the blood is taking out, getting the oxygen and coming back. So this is what is ECMO. So whenever there is ECMO, there are chances of infection. There is because they need anticoagulation. So all the things which are the, the 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 complication which can occur. Okay, two therapies investigated previously include steroid and oscillation ventilation, high frequency oscillation. Both these interventions do not improve outcome, and in the case of oscillation, may infer risk if used by a center without significant experience. Therefore, they are no longer recommended treatment option for ARDS. In summary, at present, the only intervention of ARDS which infer the mortality benefit, ventilator strategies, fluid balance, and proning. Okay, so recruited maneuver would be the most important first intervention, because, in my opinion, what I was distracted was 14 centimeter is too much. So I don't know how they have made the key. But if we just rationally think that furosemide will not be the first choice, okay, maybe it is required later on. Negative fluid balance is not optimal. They're like avoid positive balance, so even balance or judicious fluid management. And neuromuscular blocking agent should be used if increased airway pressures are faced. Okay, and this is also I think here they are saying ensure tidal volume of 6 ml per kg. I think they start with 4 ml per kg, and then according to the pressure they may increase up to 6. So I think that's why this option they have not picked. Otherwise, this is also seems to be a good option. I think they perform recruiter maneuver and incrementally increasing the to peep to above 14. I still have doubt, because in my opinion this is very high peep. Okay, so another all these questions are coming with the 26-year-old woman with a past medical history of self-harm was found unconscious at home with empty alcohol and amitriptyline bottles. So this is tricyclic antidepressant and this is alcohol. These had been ingested with half an hour. So the GCS is E1, V1, M3, so no sound and no eye opening and flexion movements. She was intubated for airway protection. Blood pressure of 80/60, heart rate of 150, QRS width of 100 millisecond. I think this is broad. I think I'm not sure about the exact. Multiple PVCs. So the next most important intervention. This is tricyclic antidepressant and alcohol, acute binge of alcohol. So NG, an administration of activated charcoal, because the history is how many hours it is anyway. Intravenous crystallite bolus of 20 ml per kg, followed by a noradrenaline infusion to maintain blood pressure. 500 ml intravenous bicarbonate for the treatment of broadened QRS complex. Lignocaine 2 milligram per kg for management of PVCs. Lipid emulsion for intravascular sequestration. I have no idea about this question. Let's see. ECA, tricyclic antidepressant. Okay. The class of drug used to treat depression, chronic pain syndromes, and neuropathic pain. And attention deficit disorder, ADHD, in children. Amitriptyline is the most commonly used in clinical practice. Overdose occurs at all ages, including accidental overdose. TCAs are some of most important overdose medications and contribute up to 300 deaths per annum. Serious collapse is due to, actually this is QT prolongation, uh, to a sodium channel stabilizing effect due to blockade of fast sodium channels in myocardial conductive system. This leads to an increase in QRS duration initially and may progress to decrease myocardial excitability, bradycardia, and asystole. In addition, a dose-dependent decrease in myocardial contractility occurs due to noradrenaline and serotonin reuptake inhibition. Okay. Alpha-1 adrenergic receptor blockade cause profound vasodilatation, which leads to distributive shock. Altered mental state results in confusion or agitation. May be a result of central, because the difference between SSRI and TCA is that it has not only anticholinergic effect, antihistaminic effect, and also these because it is inhibiting the reuptake. So there is too much um, receptor this catecholamines. Okay. Uh, okay. So increasing CNS levels of noradrenaline and serotonin reduces the seizure threshold, and the patient can have fits. The management of the patient described above should be ABC to protect the airway. Once the airway is protected, if ingestion is within an hour of presentation, activated charcoal may be considered. But I think in this option, in this scenario, it was found late. So that's why they are not doing it. But this will only prevent further GI absorption and not impact the current emergent problem of hypotension and may in fact worsen it. Fluid and vasopressors are the most important initial management. This will counteract the distributive shock component as described above. This may be sufficient to improve mean arterial blood pressure, resulting in decrease in a heart rate. The high sodium load found in sodium bicarbonate stabilizes the myocardium and may prevent arrhythmias. It is indicated if URS width is over 100 millisecond. An alternative treatment is hypertonic saline if no metabolic acidosis is present. Increasing plasma pH also has the effect of increasing drug protein binding. Increasing plasma pH also has effect of increased drug protein binding, which can be achieved by hyperventilation. Like they are doing treating the acidosis. Okay. Because in acidosis, the free drug will increase. So that's why they are doing what they are doing. Amiodarone and other class 1A and 1C anti-arrhythmic agents should be avoided as they increase the cardiac action potential. Both lidocaine and magnesium have been used for arrhythmia management in TC overdose. There are case reports that lipid emulsion has been successfully used in cardiac arrest secondary to TC overdose by sequestering plasma drug and reducing the active concentration. If used, this should follow the same protocol as for local. A multifaceted approach is required. However, the initial management should focus on airway, volume expansion, and management of vasoplegia before moving on to more complex treatment option. Actually, for this better understanding, you should go here, and here you will find poisoning. So here I think you will find a TCA, management of tricyclic antidepressant, journal principles, and just a second. You will find here the basic principle for the gastric lavage, emesis, activated charcoal. Okay, and here we few days ago we did this topic here. Okay, so treatment includes prevention of absorption using activated charcoal, sodium bicarbonate, followed by an infusion, uh, and then convulsions treated by benzodiazepine. Phenytoin may be also be used. Okay. So this question was on the basis of this TCA poisoning. Okay, coming back, you just have a look. Uh, 500 ml intravenous sodium bicarbonate for the treatment of Broaden QRS complex. Uh, this is also be used, but the on is next most important intervention. All these may be required, but the first thing to do is this because A, B, C they have A was done, so A, B was done. So actually, this is the C. So that's the basis of this answer. Okay, rest of the things are also be done. Like lipid emulsion may be used, lignocaine may be used. Uh, okay,
Sir, answer is B.
yes, B. Like you see, airway is controlled, breathing is controlled. So this is the C. So like so cardiovascular system. So but the other thing which they are telling is the whole concept what happened in TCA poisoning. Okay, there is acidosis, there is because agitation, patient can have fits, patient can have asystole changes in, you see the cardiovascular collapse can occur, so all these things can occur, and their answer is that airway is protected, so next thing is that one. And after that, sodium bicarbonate is also used, this one lignocaine may be used, and lipid emulsion is also being used. So that's how they have chalked this. So sometime whenever you are answering, you just have to think that you see this is the most important thing, the next most important intervention. The rest of the things are done. So the answer in this scenario is based off this ABC approach. Okay. So actually poisoning is a like important topic. You should be knowing about activated charcoal use and specific antidotes. So what are the specific antidotes for certain poisoning and non-specific maneuvers. Okay. Okay. So a 28-year-old woman presents with progressive and ascending motor weakness. Progressive and ascending motor weakness. She reports recent history of coryzal symptoms. So this is which disease? GB syndrome? Okay.
Guillain-Barré syndrome.
I'm sorry.
Guillain-Barré syndrome, this disease.
Yes, just Guillain-Barré syndrome. So the following would be an early indicator for the requirement of intubation. You see, respiratory rate more than 35, PaO2 less than 8, PaCO2 more than 6.5, vital capacity less than 15, absence of bulbar weakness. So what would be absence of the presence of bulbar? So this is not the answer. Again, PaCO2 more than 60, early indicator, because these things will occur late, I think. Respiratory rate will also occur late. PO2 and PCO2, I think this should be the answer. Let's see how much is, because solving MCQ is must. This is the answer. Okay. Actually, the catch in this, all are these fine and symptoms are the points are of respiratory failure. Okay, but if PO2 is gone so low, it will take a lot of time. This is a sort of failure. This is an early sign. Okay. So if vital capacity is decreased, it means patient is going towards the failure. So this is the point of this answer. Let's have a look. The symptoms of progressive ascending motor weakness with the antecedent history of a viral infection suggest GB syndrome is a collection of disease that result from acute inflammatory demyelination leading to the hallmark signs of ascending muscle weakness and areflexia. Sensory and autonomic function can also be affected by GB. The pathophysiology of GB appears to immune-mediated reaction, commonly for RTI or GIT infection with Campylobacter jejuni. Autoantibodies again, such as anti-ganglioside autoantibodies, initiate either a cascade of myelin destruction or axonal damage. Okay, the later results from Clostridium jejuni infection with a worse prognosis. Early detection of need for intubation is imperative as rapid deterioration can ensue. Indication for intubation predominantly include respiratory failure secondary to muscle weakness or the presence of bulbar symptoms necessitating airway protection. Okay. While clinical signs of respiratory failure such as tachypnea, hypoxia, and hypercapnia will strongly suggest the requirement of intubation, these are relatively late signs. That's what I was saying. Serial vital capacity measurements should be taken and management in a critical care area should be considered when vital capacity less than 20. Intubation should be carefully considered with measurements of fall below 15 in the presence of bulbar symptoms and rapidly progressive disease. Rapid sequence induction is recommended due to raised aspiration risk in addition to full AAGBI monitoring, invasive blood pressure monitoring. Why? Because there are high incidence of autonomic hyperreflexia. Okay, so autonomic reflexes will not be there. Areflexia, sorry, not hyperreflexia, areflexia. So sudden change in blood pressure can occur. Rapid sequence induction because bulbar weakness and aspiration risk. Okay, particularly in the presence of autonomic instability. Due to reports of exaggerated hyperkalemic response, depolarizing muscle relaxation should be avoided. Hyperkalemic, so neurological injury, you have to. Critical care management should include consideration of immunotherapy in liaison with specialist team, intravenous immunoglobulins, plasma exchange. Steroid do not appear to have a role. The basic thing is that it will take time. So you just have to the general ICU care, all the general ICU care with reference to bed sores, with reference to prevention of VAP, prevention of ARDS, and care of lines. Okay. The journal, what we say, fast hug. So fast hug will be there, and then you just have to wait, or because whenever there is antibodies, the plasmapheresis or this immunoglobulins will help. Okay. So this is there is an article about GB syndrome. You can write found here. Mm, okay, so you can review here. What are the
Products are
symptoms?
shown for demonstration purposes only. The AHA does.
Okay, so different types: AIDP, Aman, Amsan, and Miller-Fisher uh, investigation. There is no actually. This is a clinical diagnosis. Okay, lumbar puncture will have high proteins. Nerve conduction studies, respiratory function tests with this vital capacity and expiratory, inspiratory efforts. And maybe because patient need prolonged ventilation at some time, so maybe early tracheostomy may be needed for weaning. Okay. Mm, okay. So this question is on rifle. 70-year-old elderly awaiting elective URP to intensive care with urosepsis. His average urine output over 12 hours is 28 ml per hour. So 28 ml per hour means it's less than 0.5 ml per kg per hour. Uh, Pre-admission from 6.2 to 11.2, creatinine from 83 to 132, yeah, like 1 to 1.5. And sodium is almost the same. Potassium is going high. According to rifle criteria, which stage of acute kidney injury does this man fulfill? So it is last 12 hours, risk, injury, failure, loss, and stage. I think this is injury. Let's reconfirm. So it is injury. Okay. So there are different criteria. This rifle, Akin, Kidco, on rely creatinine rise with or without criteria for urine output. Increasing recognition that serum creatinine may not detect early AKI and the role of renal injury biomarkers such as neutrophil gelatinase associated lipocalin. I have no idea about it. This is under investigation. One of the criteria to AKI, none have show clinical superiority. All of them are same. It is with the raise of creatinine with urine output. Okay, so it is 1.5 times with less than, if it is for 6 hours, it is risk, and it is for 12 hours, it is injury. And if it is decreased urine output less than 0.3 ml per kg for 24 hour and creatinine is high, so it is failure and loss for more than 4 weeks. Okay, so that's how they describe. The patient described in this question has doubled his creatinine from baseline, and his urine output has been less than 0.5. Doubled? It's not doubled. How it is doubled? It is not doubled. It is 1.5. It was 83 and now 133. You are saying doubled. Anyways, that remember one thing. These all practice books have full of error. This is not doubled. Doubled means if it is 180. 166, then it is doubled. This is 1.5. Okay, so this is an error. When we were preparing for the exam, in every book there are so many questions which has errors. So never trust 100%. Yes, you can follow them. They are really good, and actually the good thing is that they will put the reference. So you will find here the reference for this. See, they will tell the nice guideline. It is on the nice guideline, so you will find it. But the thing is that there are small mistakes in it. Yeah. So I think we will stop here, and inshallah we will continue. The basic purpose of like the take home message, if you are following it, you the today's topics were that this is a small AKI, how you identify. Then we have this GB syndrome. Okay. Then we have this poisoning. So you have to make sure you read the journal principles of poisoning management, which will be according to the clinical sign symptoms. Okay. And history will tell you something. There may be no history. You don't have a definitive history, or there is a definitive history like this. And then there are some manuals which are journal, and there are some manuals which are specific to some certain poisoning. So this is the learning objective in this MCQ. Okay. Then there was a question on ARDS where I still have a doubt about this 14 centimeter. If any one of you can read in detail about the recruitment manual and up to how much PEEP you go, I will be obliged, because I think this seems to be more appropriate answer than this one. It's only written because 6, so maybe because usually it is 4 to 6. So how they have taken this, I think, anyways. So usually we follow the PEEP is the second stage, not the first thing. So I have doubt on this question also. Rest of the question was on this cardiac tamponade. Okay, so you should be knowing about this back striate, because that will be a sign of failure, uh, that it's an emergency. And this question was on head injury, and we discovered that how we should be intubating this patient. Okay, so thank you very much. Uh, any question, anytime, you are welcome. Okay, thanks a lot, all of you, for joining, and best of luck.
Thank you, sir.
Bye.